What I'm going to be talking about is just sharing a little bit of a roadmap and an experience of going from the idea to scale, and some of the pitfalls along the way. And it's not going to be a travel log, 1,000 slides. Isn't this boring? But it's really hopefully it'll be a little bit generalizable as well. But it really is piped to reality, and how does that scale? How does that become a reality is critical. And so the words, instead of a word cloud, we have a word list on both sides, from pipe dream to reality. And I think that those are the sort of topics and the things that are critical to coming up with an idea, seeing if it matters. Will was talking about the iteration, whether it's reflection in education. Something can be so clear to you that it may not be as clear to other people, or maybe the words you use mean something else to other people. And so you think you're talking about I don't know, improving care, and somebody else thinks you're talking about IAG profiles on computerization or plumbing, electrical plumbing or something. And then when there truly is a lot of a seat of the pants, the intuition, the luck, the timing, the people that are supporting you that you don't even realize how critical they are. In my own case, there's a fellow named Craig Jones, for example, up in Vermont. He runs something called the BluePrint for Health, which is a statewide initiative where they're doing quality improvement. It's a medical home demonstration. It's all paid for. They have care managers. They have all the stuff we're all trying to move towards. And we came across each other probably in 2002 when he was doing innovative disease management with an mobile asthma bus in California, and kind of hit it off, and sort of like what all we're doing. Turns out the BluePrint Phase 1, and not to be confused with Picasso's Blueprint, but the BluePrint Vermont Phase 1, the plumbing piece didn't work so well, and so they did a reboot and a restart, and they brought Craig in because of his experience. And so 8 years later, or somewhere along there, one of the most important connections I had was one of a zillion holes that was dug along a 12-year process that all of a sudden popped to be, and there's no way you could anticipate, oh, asthma bus is going to become coordinator for a statewide disease management medical home. And that's how this stuff, I think, ends up really working. And at each step, sharing the passion. The people, the innovative companies, it was a blast to read the abstracts. People have a lot of passion. They're great ideas. Some of them are going to tank, and some of them are going to take off. And I bet it's not the ones that we think are going to take off are going to be the ones that will take off, because nobody really knows. It's complex dynamics. At the end of the day, it's important to have people around to make sure people care about it. So this goes from the top down, and it's not just Farzad on the technology side. If you talk to Don Berwick, he's in the same place. I know Anish and others, Todd Park. I suspect the secretary, I don't have active direct, but across the board, and frankly, the head of the executive branch is an innovator, and Congress is supporting innovation. It's going to change, it's going to work, but defining the problem is a critical piece. So what else are critical pieces? It takes time and effort. It's on a personal level, it was about a dozen-year process. And this was, we moved recently, and I was cleaning out the basement, and they found a pile of tags. I thought that would be a fun picture. And that's not anywhere near all of them. And when you think it's going to be okay and it's going to work, you may not even be close to there. So if this is these are bullet points from an article. We were all excited. Boston Business Journal did this article about, we had our picture on the front of it, and we were the innovators. We had these little Windows CE platforms, and we were going to do data entry for healthcare, and it was going to all be great. And this was 1997, and wrong time, wrong place, wrong system, and we had this afterthought thing called CareFlow, which is a program to assess patients and do chronic disease management and proactive steps. The first one was a home care documentation system on WinCE, and there's somebody here who, ironically, in Pennsylvania, had a parallel company. We were just talking out here. Same thing in 1998. Front page of the Pennsylvania Business Journal, and it's the ideas are good ideas, but if they're not a business idea and they're not scalable, it could be totally the wrong time. This care process thing, which ended up ultimately being the root of what we did, was the right idea, but nobody's writing a check for between organization care coordination and care management in 1998. And so the clinicians were dealing with it. I'm a physician and worked at a geriatric continuum and saw the issue of the patient going for, now we call it transitions of care, but all the different levels, and nobody knew which end was up. But nobody was paying for it. And so this is here, we filed this thing in June 1998, or January, whatever that is. Does this look that familiar? Of here's a cloud, and here's reaching to the computer, or the fax machine, or a telephone, and here's somebody putting in the data, and you've got assessor programs, and identification and filtering programs. So right problem, wrong time is a really bad idea. Simplifying it becomes important. This ended up being, this was sort of in the 2002-ish range or somewhere in there, of coming up and saying, you know what, this is the round trip. Identify, stratify, plan, intervene, and measure. And so the filtering and the funneling, and then you can turn it into a plan that you can distribute across a team, place, and time. And this picture in the slides used to have a picture of a thermostat in the middle too, with this patient on the side. And this one, that resonated with people. That sort of simplified it. And then we figured out that if you talk about a couple patients, the narrative, Don Berwick for years has been doing the narrative with IHI, that becomes a critical piece. And so talking about it wasn't enough, but when we turned it into Mrs. T and Mrs. J, 80-year-old, heart disease, diabetes, and 8 meds, what they look like from claims, and then talked about their real needs, this ended up resonating. Whether somebody's got an issue with a lot of functional problems, or not enough finances, or maybe has addiction issues but plenty of finances, and one's going to break a hip from drinking too much, and the other maybe in a nursing home. Then another piece of it is you can't necessarily displace everything that was there. We were arrogant as hell at the beginning, thinking, oh, this is such a great idea, just go buy this thing, and didn't understand how business worked, how any of this stuff worked, because people had already bought stuff, and they were proud of what they bought for good reasons. Somebody spends $40 million on an EMR system, and they're not going to ditch it for sure, and nor should they. And it solves a lot of other issues. But it may not solve some of the care issues. So then how do you layer the thing on top? So we've started walking down saying, well, the health plans are doing care and disease management, talking to the patients, and they've got a transaction system that exists. Most of them had clinical intelligence systems, and in the office you had a billing system, and you had prescribing, not necessarily electronic, but you still had the feeds around it. And so that was the ecosystem that we were going into. And so then we said, you know what we're trying to do is make care better and faster. So how can you put that in, and what has to happen? You have to connect potentially to to data that's in an organized fashion, and you have to create communication so you don't have a disease management system that's separate from a care delivery system. And lo and behold, what are we doing? We're putting it all together now to say, here are centralized care managers at plans and embedded care managers in practices, and they're working together. And then this whole EHR, registry, decision support, EMR, ABC, this is the language mess was just heinous on this stuff, and still is. That if something's a core billing system, does that make it really do care coordination, or vice versa? And just a few more slides to finish the story. There. So at the end of it, the what is really easy. The when is really tricky. And this is sort of the progression. On a personal level, I had the luxury of doing engineering and medicine, and kind of crossed over. I had a bone cancer about 30 years ago at the NIH. And by the way, parenthetically, I tried to look at my patient record once when I was traveling from floor to floor. There was a canvas bag, and it had a zipper and a lock, and somebody left it unlocked, and I opened it up, and man, I thought that all the alarms were going to go off and everything else, that I was in trouble. And then I sit on the advisory board over at the clinical center at the NIH now. John Galen, who runs it, has a patient advisory board, and we have these discussions about when can the patients get immediate access to the data. And so same thing, timing. 30 years ago it was an anachronism to have a patient look at a record. Now, how do we pull people in as partners? But the root of the problem identification was doing the practice. A lot of people have rooted their issue. Trying to do that first thing, Cognimed, better care costs less. And we were one reorg away from a brass ring of scale with a health plan. It was about a $15 or $20 million project to take over their care management risk. We had it reinsured, and the whole thing was ready to go, and then there was a reorg. So that fell to the wayside. We got bought by another company called Active Health. That was an example of putting the wrong pieces together, sort of a quick story. There were 4 companies that came together, and on paper it all looked good, but nobody knew how to integrate cultures or anything else. Somewhere in New York, somewhere in Massachusetts. It was pre-internet time, it was all moving forward, and it kind of ended up being a mess for everybody. The end game of it was we spun DocSite back out, and then Active Health went forward, got bought by Aetna, which was a good thing. On a personal level, I realized there wasn't any understanding of how healthcare as a system and a financial system worked. And so spent a few years at a company called DXCG, which made the risk adjustment models that Medicare uses, expected versus observed cost. And it was wild. An actuary could write a check in 5 seconds for 50 grand. It was, I want to do it? Okay, great, I'll send the check tomorrow. Care management, the medical director couldn't write a check for 50 grand, even at massive health plans, if it was, 6 months later. It was an influencer, and this concept of who can write a check. Who are you talking to? Is it the right person becomes important. And then working it forward as a small company with as a self-funded small company as DocSite, we had the right thing. We had a luxury of a 4th generation product when everybody wanted to do all this readmission and care coordination, and there was no way in heck it was going to scale. And so we did finally end up with the brass ring of scale through merging in with a company called Covisint, which had, they make for OnStar, all the endpoints and the secure endpoints, that's all Covisint, supply chain with automotives, and they went into healthcare with healthcare exchanges and things, and now have brought some vertical pieces together to put it in. And it was the perfect match because they had scale and people and resources and an appetite, and we had a mature product. They couldn't build a mature product fast enough, and we couldn't scale with a national team and other pieces. And frankly, we did it back in September, and it was 1 step back and 2 steps forward. We went back, it was redo of the wrong language type of stuff, and what do these words mean? And now it's 2 steps forward, and it's accelerating fast. So the end game of this, and I'm sorry for talking so fast, we're supposed to try and keep us all on time, it's keep it simple. Harvest along the way and learn. It would have been so much smarter to harvest some of the things along the way and restart as the next company to go forward versus try to just take the whole thing forward. The eye on the changing environment, Will was talking about that. And too far in front is not necessarily a good thing. It can be fun and rewarding, so you got to figure out what that reward is. And I'm going to not go through the rest of it, I think. The entry, exit stages of growth. If you want to see an interesting, innovative company, and I was just trying to use an example, ZocDoc is open table for doctors, and somebody couldn't figure out who a dentist or a doctor was, and turned it into a company, and did a prototype, got funded, ended up with the folks who, Bezos and stuff, some of the guys who've done a gazillion huge things wanted to play, so their $3 million round became a $5 million round, and now they're doing spread. They got $15 million bucks, and you can look at their web hits and how it's all going, and it's a very simple problem. Move forward, and it's going like lightning. So the healthcare needs fixing. It's still very early in the story, and today's the date.